Thank you, Dr. Friedel. Try and keep it simple here.
Green arrow, forward. Red arrow, back. No.
Definitely know I'm a surgeon, huh? All right. I have no disclosures. So esophageal cancer is the sixth leading cause of cancer death worldwide, and that's principally due to squamous cell histology. In the U.S., adenocarcinoma is our prime variety, and the incidence of this particular cancer has increased greater than 1,600% during the second half of the 20th century. Surgery has always been and kind of remains the cornerstone of treatment for this particular disease. Currently, we have both open and minimally invasive esophagectomy options available to us, and there are ongoing comparisons between both of these options to try and define safety, outcomes, and oncological equivalence. However, despite the fact that we've got over 17 comparative trials, 2 meta-analyses, 2 systematic reviews, and the latest randomized controlled trial out of the Netherlands, the problem is that there's only a limited number of patient factors that really have been examined. And little attention has been given to patient comorbidities. That's not to say we haven't considered comorbidities as surgeons. We certainly have. Over 30 years ago, Feinstein and his colleagues were the first to suggest that comorbidities do influence prognosis in laryngeal cancer. And they found here in particular that their 5-year survival in laryngeal cancer patients dropped from 54% down to 15% in the presence of severe prognostic comorbidities. These findings have subsequently been confirmed in endometrial cancer, breast cancer, and even after individuals undergoing prostatectomy. And that has led a lot of individuals to suggest that comorbidity is an independent risk factor for survival in cancer patients. Now, the Charlson Comorbidity Index is the primary instrument we will use when we try and actually quantify comorbidity for a lot of our clinical trials. It's been around for over 25 years. Mary Carlson first defined it in 1987, and it's been validated and utilized in a large number of different settings over the course of that time. In her original investigation, she identified 19 different conditions, which are outlined here in the table on the left, which is actually a table from her original paper. She identified 19 different conditions that had a significant association with mortality in a group of 559 medical patients that were followed for a year. Based on the relative risk of death related to these conditions, she assigned a weight, and the summary of all the weights give you a composite comorbidity score, or a Charlson score, which is familiar to a lot of us when we comb the literature. Now, Singh and his colleagues, otolaryngologists, took things a little bit further in 1987. They were looking at the prognostic value of the Charlson Comorbidity Index in 88 head and neck patients, and they found out not only was it valid, but it also was independently predictive of poor survival in their patient population. They also defined a comorbidity grade, which is shown here on the right, by simply combining increasing levels of comorbidity index score into a very convenient grouping. So as we can see here, which each individual score, none being no comorbidity whatsoever, 1 being low grade, 2 being intermediate, and 3 being advanced comorbidity, we have increasing grade score. They found that not only was it just as valid as the Charlson index, but it was easier to apply, and particularly for surgeons who usually just count to about 3, it was a perfect instrument to use. So with that in mind, the specific aims of our study here were, number 1, to examine the impact of comorbidities in patient characteristics on surgical outcomes and long-term survival after open and minimally invasive esophagectomy. And to do this, we used the Charlson Comorbidity Grade Index, which we call the Charlson grade, as the comorbidity variable. Secondly, we wanted to just add to the global body of knowledge that's in process right now to assess the safety and oncological equivalence of MIE when compared to open esophagectomy for the treatment of locally advanced esophageal cancer. This was our retrospective review of a prospective esophageal registry maintained at OHSU. This is an IRB-approved study. All patients underwent esophagectomy. All patients undergoing esophagectomy for stage 2 and 3, which is locally advanced cancer, between June 1995 and July 2011 were included in the study. There were 146 of them, which we separated into 2 groups. The open group was 64 individuals, and the minimally invasive was 71. There were 11 conversions, mostly for adhesions, some for technical issues, and they were classified as minimally invasive on an intent-to-treat basis. All patients had clinical staging, e.g. upper endoscopy, CT, and PET, and we added other modalities such as endoscopic ultrasound and PET-CT as they became available. This is demographics for our patient population. There was no significant difference in terms of age, gender, body mass index, Charlson grade, clinical stage. We did have a significant difference between the 2 groups in terms of neoadjuvant therapy. Over 90% of our patients in the minimally invasive group received neoadjuvant therapy, whereas only 61% in our open group received this. Operative and postoperative outcomes are seen here. There were differences, significant differences in our approach, and so the fact that 83% of our individuals who underwent the laparoscopic approach did so through a 3-field technique, whereas 88% of the open group had the classic Ivor-Lewis approach. There was also a significant difference in terms of blood loss favoring the minimally invasive group, and in nodes removed, where we had a median of 7.4 additional nodes removed during that procedure. Otherwise, no significant difference in the number of positive nodes or in the pathological stage to follow. To round out our postoperative outcomes, there was no difference in perineural invasion. You can see here that we had a 95% R0 resection rate in our minimally invasive group, but compared to our open group, this is not significant. There was no significant difference in pathologic complete response, but there was a significant difference seen in length of stay, with our open group staying on median 1.5 days longer than our laparoscopic group. ICU stay was low, and 30-day morbidity was very, very acceptable. Major complications, we tracked about 24 major complications after this procedure. I've listed only the ones that are in frequency, 5% or greater frequency. And as you can see, atrial arrhythmias, AFib, aflutter, and so on were the most common complication in our patient population, 33% in both groups. This was followed by pneumonias, 16% in our laparoscopic group, 9% in our open, but these were not significant. There was no significance either between the aspiration pneumonia rate between the 2 groups, anastomotic leak, stricture rate, superficial wound infection. We do see here there's a significant difference between the recurrent laryngeal nerve injury rate between the 2 groups. 6 of our patients in the MIE group had a recurrent laryngeal nerve injury, none had in the open group. And this again just speaks to the morbidity associated with a neck dissection. 2 of our conduits went down in the minimally invasive group, 3 went down in the open group. Again, this is not significant. And this is our multivariate model. We used all of our demographic variables, which I've also listed on the bottom here as well, as part of the modeling system. And as you can see, the Charlson grade is very well represented across a wide variety of outcome variables here. Our Charlson grade 3 is significantly associated with increased operative time, while it's also associated with increased length of stay in conjunction with BMI and approach. Our Charlson grades by themselves, whether it's grade 1 or grade 3, are independently prognostic of increased cardiovascular complications, wound infections, anastomotic leak, and overall survival. So Kaplan-Meier overall survival curves. We've now got data out to beyond 5 years. At 5 years, we have a 42% survival rate in our MIE group, a 37% survival rate in our open group, and this is not significant. I've also posted our hazard ratio as far as clinical stage is concerned, and we can see here that although moving from a stage 2 cancer to the worst stage 3 cancer imparts probably about a 47% increased risk of dying, this is not significant with a fairly tight confidence interval. So in conclusion, we found that pre-existing comorbid conditions have a significant impact on selected postoperative outcomes, that comorbidity acts as an independent risk factor for overall survival, either after open or minimally invasive esophagectomy, and that minimally invasive esophagectomy is comparable to Lewis, the Ivor-Lewis approach in terms of complications and oncological outcomes to a median follow-up beyond 5 years, which is in keeping with what we're finding in the literature. I'd like to thank you all and thank the Society.
Thank you very much. If there are questions, please come to the microphone. I would like to start with the first one. Would you go as far to say, you know, if you have a preoperative high risk factor, that you would use this also as a decision to go for a minimal invasive technique rather to open?
I think we do that now, and I think we're seeing a selection bias in terms of what we're doing. We're tending a lot towards minimally invasive. Even with our, I think even with somebody who has considerable comorbidity, we'll refuse them an operation, whether it's going to be open or whether it's going to be minimally invasive. And you can see that in our Charlson scores. There are very few of those individuals with a Charlson of 3. They're all otherwise fairly healthy. They still have a morbidity, and I think we would probably still offer them the open procedure rather than the laparoscopic rather than the open procedure.
Okay. Thank you. Please.
Hi, Stephen Bowers from Jacksonville. Jim,
Who's that? Dr. Bauer?
You guys are obviously doing a great job with MIE. A lot of things have changed since '95. Can you give us an idea of what percentage of your cases were done open early in your experience versus currently? Because how much of the reduction in comorbidity could be due to other things, protocolized anesthesia care, some preconditioning that you're doing, better ICU care? Thanks.
Yeah. I think you've kind of highlighted the problem we have with this retrospective review. And the fact is, earlier on, I think, probably in '95 towards 2000, it was probably 60-40 was our ratio as far as open versus minimally invasive. And since 2000, or particularly 2003, that's kind of reversed. We do predominantly all minimally invasive procedures now. If we do any sort of open procedure, it's in individuals who already had multiple laparotomies, or so there's some other reason to do so. So we clearly are introducing a bias here. I think our somewhat historical controls in our open is going to figure into that as well. Obviously, we didn't have endoscopic ultrasound. We didn't have PET CTs back in the late 90s or so. We had fairly decent, but otherwise fairly crude ICU care. And nowadays, we've got a multidisciplinary team that takes care of all these individuals as well. So I can't but believe that that has an impact in care as well. In fact, there's public literature out there that does support that as well. So yes, we're kind of changing things as we go along just because of our approach.
All right. Thank you very much. We go on.